Finals SAQ 75 Post-dural puncture headache. A woman experiences a headache 24 hours after delivery, having had epidural analgesia for labor. A. List the clinical features of Pdph. From the history, known or suspected dural puncture, with or without multiple attempts, use of large bore needle, cutting needle used, junior anesthetist, or patient was in sitting position during LP. Fronto-occipital headache, developing within 5 days of dural puncture, worse on standing or sitting, improves on lying flat. Headache is often absent after overnight bed rest but returns after mobilizing. It affects daily activities if severe. 5% of Pdph are not postural. Untreated, they are said to last 7 to 14 days. The headache may be accompanied by neck stiffness, pain in the cervical, thoracic or lumbar vertebral area, tinnitus, hypoacusia, vertigo, photophobia, difficulty in accommodation, and nausea. Physical examination is mainly to rule out other causes. Temperature is normal. CVS examination, especially blood pressure, is normal. The headache may be relieved by tight abdominal compression. Neurological examination is usually normal, but neurological signs may occur, such as blindness, diplopia, tinnitus and hearing loss, head and facial pain, and neck pain if cranial nerves are involved. Rarely, CSF leak from the puncture site on the back may be found. B. What are the differential diagnoses of Pdph? This includes infective causes such as meningitis, encephalitis and sinusitis, metabolic causes such as dehydration and caffeine withdrawal, vascular causes such as migraine, cerebral vein thrombosis, cerebral infarction, subdural hematoma, SAH, posterior reversible leukoencephalopathy syndrome, and pituitary bleeds. Obstetric-related causes include preeclampsia and lactation headache. Neoplastic causes include primary or secondary tumors. Other causes include tension headache, benign intracranial hypertension, pneumocephalus, anemia-induced headache, drug-related headache, and spontaneous intracranial hypotension. C. Outline the conservative treatment options for Pdph. Conservative treatment aims to alleviate symptoms while waiting for the dural tear to heal. Adequate oral or IV hydration. IV fluids should be used when oral hydration cannot be maintained. Excessive fluid intake may be harmful. Regular multimodal analgesia, including paracetamol and NSAIDs, unless contraindicated. These are mainstays for symptomatic treatment. Short-term use of opioids may be considered in the treatment of Pdph if regular paracetamol and NSAIDs is ineffective. Long-term opioid use is not recommended in the treatment of Pdph. Caffeine reduces intracranial vasodilation, which is partially responsible for the headache. This may be offered in the first 24 hours of symptoms with a maximal dose of 900 mg per day, 200 to 300 mg if breastfeeding, and avoid multiple sources to prevent adverse effects. Antiemetics if required, stool softeners to avoid straining. Bed rest alleviates symptoms, but the effect is usually transient, and this increases the risk of VTE. Evidence does not support the routine use of bed rest to treat Pdph, although it may be used as a temporizing measure for symptomatic relief. Thromboembolic deterrent stockings and consideration of low molecular weight heparin prophylaxis if the patient is immobile for 24 hours or more. Time heparin doses to avoid delaying epidural blood patch if needed. Encourage mobilization, regular reassessment and communication with the woman and community midwifery team if discharged. Written discharge paperwork to accompany the woman. There is insufficient evidence currently to recommend the following: sphenopalatine ganglion block, greater occipital nerve blocks, theophylline, ACTH analogs, steroids, triptans, gabapentin, acupuncture, epidural opioid or fluid, neostigmine, atropine, pyritramide, methergine, abdominal binders, and aromatherapy. D. How is an epidural blood patch performed? The patient should be suitable. No signs of sepsis. No contraindications for epidural blood patch such as anticoagulation, coagulopathy, thrombocytopenia, defect in platelet function, infection at the injection site, patient refusal, lack of cooperation, and other contraindications for epidural injection. It has been more than 24 hours since the dural puncture. Other causes for headache has been ruled out, and signs of cranial nerve palsy is an indication for epidural blood patch. Written information should be offered to the patient. Written consent should be obtained. Risks should be explained, including local bruising on the back, backache and stiffness which can last for days, another accidental dural puncture, nerve damage including cranial nerve damage, arachnoiditis, seizures, infection, bleeding, and failure to treat the headache in 30 to 40%. If an EBP is performed within 48 hours of dural puncture, the patient should be counseled about a likely need for repeat epidural blood patch to achieve symptom resolution. 2 anesthetists are required. Ideally, one should be a consultant and experienced epiduralist. The other is required to take blood in a sterile manner. The patient may benefit from a period of bed rest before performing EBP to reduce CSF volume in the epidural space. There is insufficient evidence for prophylactic antibiotics before EBP. Consider radiologic guidance if EBP cannot be safely performed with landmarks alone. EBP should be performed in operation theatre environment, establish IV access, full asepsis for both anesthetists. Evidence does not support the routine use of blood cultures before EBP. The consultant locates the epidural space at or one space below at which the dural puncture has occurred. Because injected blood is thought to spread in a cephalad manner, the woman should be in a lateral position to minimize CSF pressure in the lumbar dural sac. The other anesthetist withdraws 20 ml of blood aseptically. Blood is injected via the Tohi needle until pain in the back or legs occur or all 20 ml are used. Blood should be injected slowly and incrementally. If pain occurs, pause, and if the pain resolves, try continuing a slow injection. However, if pain recurs, stop injection. Flush the Tohi needle with saline before withdrawal. Ensure the patient lies flat to allow clot to form. There is insufficient evidence to recommend a specific duration of immobilization after EBP. However, lying flat for 1 to 2 hours post-EBP has been suggested. Advise no lifting of weight heavier than the patient's own baby, straining, excessive bending, and air travel for 2 days to avoid disruption of the EBP. Prescribe stool softeners or cough suppressants if indicated. Until symptom resolution, regular patient follow-up should be undertaken to determine the need for repeat EBP in cases suggestive of persistent or severe CSF leak. After an EBP, if backache persists or increases in severity or changes in nature, other diagnoses should be investigated. Written discharge summary for the GP and community midwife and the woman to include issues that should prompt reattendance at the hospital and contact details of the anesthetic team should be prescribed. Additional questions. March 2017 FRCA. The obstetric team tells you about a patient who is 2 days postpartum with what they suspect is a Pdph. A. What is the differential diagnosis of Pdph? The answer to this is exactly the same as part B of the previous question. However, one must include Pdph in the differential. B. What features in this patient would lead you to consider a serious underlying cause? In the history, drowsiness, confusion, vomiting, focal neurology, seizures, significant neck stiffness and photophobia, history of head trauma, and bleeding tendencies. Physical examination, focal neurological deficits, papilloedema, hypertension, hypotension and tachycardia, fever, reduced consciousness, meningism, and petachy. Investigations, signs of infection, such as raised CRP and white cell count, features of preeclampsia, such as deranged transaminases and bilirubin, low platelets, hemolysis, elevated uric acid and proteinuria, coagulopathy, and thrombocytopenia. C. You diagnose a Pdph and arrange treatment by epidural blood patch. What are the risks of epidural blood patch? This has been discussed in the previous question. Additional Q&A. Define Pdph. The 2018 definition by the International Headache Society defines Pdph as a headache attributed to low CSF pressure occurring within 5 days of a lumbar puncture caused by CSF leakage through the dural puncture. Weaknesses of this definition include neither opening nor closing pressure has been shown to differ in studies of patients with Pdph compared with controls. Patients with intracranial hypertension can have Pdph. Case reports and series have shown that Pdph may become apparent more than 5 days after dural puncture or after hospital discharge. Omission of the post-dural component is controversial. Dural puncture may not be noticed during the procedure. Headache can persist for longer than 2 weeks. This definition requires evidence of low pressure or CSF leakage on cerebral imaging. What is the pathophysiology of Pdph? The pathophysiology is incompletely understood. When loss of CSF through a dural tear is greater than production, CSF pressure falls and the brain sinks due to reduced buoyant support, resulting in traction and pressure on pain-sensitive structures within the cranium, such as dura, cranial nerves, bridging veins, and venous sinuses. Compensatory vasodilation of intracranial vessels may further worsen symptoms. Multiple neural pathways are involved in generating the symptoms of Pdph, such as frontal head pain, cranial nerve V1, occipital pain, cranial nerves 9 and 10, neck and shoulder pain, cervical nerves C1 to C3, nausea, the vagal nerve, auditory and vestibular symptoms due to direct communication between CSF and the perilymph via cochlear aqueduct, which results in decreased perilymphatic pressures in the inner ear and imbalance between endolymph and perilymph. Visual disturbances due to involvement of cranial nerves 3, 4, and 6. Other cranial nerve palsies include cranial nerve 5, 7, and 8. Discuss the epidemiology of Pdph. Inadvertent dural puncture occurs in less than 1% of epidurals. Up to 40% of inadvertent dural punctures may not be recognized during the procedure. If dural puncture occurs with 16-gauge Tohi needle, risk of Pdph is more than 50%. If dural puncture occurs with 25-gauge spinal pencil point needle, risk of Pdph is 2 to 10%. Severe headache requiring epidural blood patch is 1 in 650. If severe Pdph is untreated, headaches are not only unpleasant but may rarely be life-threatening due to complications such as intracranial hemorrhage, subdural hematoma, cerebral venous thrombosis, and coning of the brainstem. Patient factors associated with the incidence of Pdph includes younger age, female sex, and history of headaches. When should Pdph be suspected? Pdph should be suspected if headache or neurological symptoms, which may be relieved when lying flat, occur within 5 days of a neuraxial procedure. Recommendations include inpatients who have received a neuraxial procedure should be reviewed and evaluated for symptoms of Pdph. Outpatients should be instructed to report symptoms of Pdph to their physicians. What procedural characteristics are associated with Pdph? Compared with cutting needles, non-cutting spinal needles are associated with decreased Pdph risk. There is limited evidence regarding a particular design of non-cutting spinal needle in affecting the risk of Pdph. When using cutting needles, narrower gauge needles reduces the risk of Pdph. For non-cutting needles, limited evidence suggests narrower gauge needles reduces the risk of Pdph. Evidence is insufficient to confirm benefit of any technique used to identify the epidural space on reduction of the incidence of Pdph. Increased number of attempts of neuraxial technique increases the risk of Pdph. A higher level of operator experience reduces the incidence of Pdph. There is a lower risk of Pdph if neuraxial techniques are performed when the patient is in the lateral decupidus position. Recommendations: routine use of non-cutting spinal needles for lumbar puncture for all populations is recommended. If using a cutting needle for lumbar puncture, the use of narrower gauge needles is recommended. Limited evidence supports the use of narrower gauge non-cutting needles over larger needles for lumbar puncture to reduce the risk of Pdph. If using a cutting needle for lumbar puncture, insertion of the bevel parallel to the long axis of the spine is preferred to reduce the risk of Pdph. What measures may be used to prevent Pdph? After inadvertent dural puncture during attempted epidural catheter insertion, evidence was insufficient to confirm that placement of an intrathecal catheter decreased the risk of Pdph and EBP. A policy of routine prophylactic epidural blood patching exposes the patient to unnecessary risk. Evidence of reduction in severity of Pdph with prophylactic bed rest was inconclusive. Recommendations: after inadvertent dural puncture during epidural catheter placement, an intrathecal catheter may be considered to provide anesthesia or analgesia. Consider the potential risks associated with intrathecal catheters. Prophylactic EBP is not recommended. Bed rest is not routinely recommended as prophylaxis against Pdph. Routine injection of any substance intrathecally or epidurally to prevent Pdph is not recommended. There is insufficient evidence to recommend routine systemic drug administration for Pdph prophylaxis. Describe the immediate management of an inadvertent dural puncture. The aim is to achieve effective analgesia without further complications. If a dural puncture occurs, a catheter can be threaded in intrathecally and left in situ, or removed and an epidural catheter reinserted. The patient should be informed at the earliest opportunity that a dural puncture has occurred and the likely sequelae. All patients at risk of developing Pdph should be reviewed daily by an anesthetist until resolution. The intrathecal catheter technique. After dural puncture, do not move Tohi needle. Pass 2 to 3 cm of the catheter into the subarachnoid space. Label the catheter clearly as an intrathecal catheter and only allow anesthetists to perform top-ups. Give through the catheter intermittent top-ups of 1 to 2.5 mg of bupivacaine with or without 5 to 25 mcg of fentanyl for adult dose. Tachyphylaxis may occur with prolonged labor. Make sure the dead space of the catheter and filter is known and accounted for, usually 1.1 mL. The dead space can either be left with a known solution or flushed with normal saline after each top-up. Communicate and document which technique is used. Advantage of the intrathecal catheter technique is that chance of performing another dural puncture is removed and the need for epidural blood patch may be reduced. Another advantage is excellent quality of analgesia. Risk includes unfamiliarity with dosing, tachyphylaxis, and movement of intrathecal catheter out of the intrathecal space may compromise quality of analgesia. The intrathecal catheter may be mistaken for an epidural catheter. The next technique is removal of the Tohi needle and epidural catheter and reinsert the epidural catheter at a different interspace, usually a space higher. Consider asking a senior colleague to help. Run the epidural as normal, but beware of intrathecal spread of LA causing high blocks. When large top-ups are given for an operative procedure, intrathecal spread through the dural tear can result in unexpectedly high block. All top-ups should be given cautiously by an anesthetist. Prophylactic epidural blood patching has fallen out of favor. Is imaging required in Pdph management? Evidence was insufficient to assess the risk-benefit balance for routine cranial imaging before EBP for Pdph. Ultrasonography-assisted EBP had the utility for landmark clarification before epidural blood patching or for imaging guidance in patients who are unable to receive fluoroscopy or CT scan. Recommendations: brain imaging may be considered when non-orthostatic headache is present or develops after an initial orthostatic headache or when headache onset is more than 5 days after a suspected dural puncture. Focal neurologic deficits, visual changes, alterations in consciousness, or seizures, especially in the postpartum period, should prompt neuroimaging to evaluate alternative diagnoses. When should an epidural blood patch be performed? It should be performed when Pdph is refractory to conservative therapy and Pdph impairs activities of daily living, EBP should be considered to treat headache and other neurological sequelae of intracranial hypotension. In patients with Pdph with severe neurological symptoms, such as hearing loss and cranial neuropathies, EBP should be considered as a treatment option. What is the mechanism of action of an epidural blood patch in reducing Pdph? The first mechanism is blood injected into the epidural space, compresses the dural sac and raises ICP, which produces instant improvement in pain. Second, blood forming a clot over the dural tear seals the CSF leak and the dural sac gradually refills. What procedural interventions may be used to treat Pdph apart from epidural blood patch? Efficacy of greater occipital nerve block for Pdph is unclear. Epidural saline may give temporary benefit, but is not expected to provide long-lasting relief for Pdph. Neurological closure of dural tear has been performed. Evidence does not support routine use of acupuncture or sphenopalatine block to treat Pdph. Greater occipital nerve blocks may be offered to patients with Pdph, although headache may recur in substantial portion of patients. Evidence does not support the use of spinal or epidural morphine to treat Pdph. Evidence does not support routine use of epidural dextran, gelatin, or hydroxyethyl starch to treat Pdph. Evidence does not support routine use of fibrin glue to treat Pdph. Fibrin glue should be reserved for management of Pdph refractory to epidural blood patching or when autologous blood injection is contraindicated. The use of fibrin glue in the treatment of Pdph has been associated with anaphylaxis and aseptic meningitis. What are the long-term complications of Pdph and how should patients be followed up? Evidence showed an association between inadvertent dural puncture and Pdph with chronic headache, backache, neck ache, depression, cranial nerve palsy, SDH, cerebral venous sinus thrombosis, and coning of brainstem. Evidence was insufficient to determine whether EBP prevents or treats these sequelae. Recommendations: before discharge, information regarding Pdph sequelae should be conveyed to the patient, with arrangements for follow-up and contact information of their anesthesiologist and other healthcare practitioners. The clinician responsible for dural puncture leading to Pdph should ensure that other specialties or primary care physicians are informed of Pdph management and the potential for long-term symptoms. Follow-up with patients who experience Pdph should continue until headache resolves. After discharge, follow-up may be continued by the primary care physician. Information regarding Pdph, inadvertent dural puncture, and other sequelae should be communicated to the primary care physician, with referrals to a pain or neurology specialist if indicated. Urgent neuroimaging and referral to an appropriate specialist should be performed for any patient with Pdph who has worsening symptoms despite epidural blood patch, new focal neurologic symptoms, or a change in the nature of headache. Epidural analgesia and anesthesia can be effective in patients with a history of epidural blood patch and should not be withheld. These are my references. Thank you.